this is MS4 graduating lecture curriculum, right? So this is going to be a brief discussion about primarily shock recognition, and we'll get a little bit into initial shock therapies or treatments. Recognizing your role and as you start to interface with patients, you're going to be exposed to a lot of fragile patients in the hospital. And a lot of those patients are going to suffer adverse outcomes because they have evolution of malperfusion organs that result in multi-organ dysfunction. Maybe I'll also add that when patients have sudden events in the hospital, cardiac arrest or rapid response team events, they are typically preceded by minutes, if not hours, of clues of progressive cardiovascular dysfunction. And so I want you guys to be pros at at interpreting and finding those situations so you can call for help and start to apply the right therapies early. Okay. This is intended to be interactive, but there is no bad response. Also we wanted to answer any questions, so don't be bashful, shoot up a hand, don't wait till the end. Okay. All right, so let's start for a second and say, so we're all grounded. What is the definition of shock?
Constellation of symptoms or signs or signs rather than like an actual.
Well, I think we could probably come up with a definition. We use a cadre of symptoms and signs to try to recognize it. Maybe I'll ask a couple of people for some comments. Say again.
Oh, yeah.
Is it like an insult to the body that causes hemodynamic instability?
It's the hypoperfusion. Hypoperfusion. Okay, we're getting closer. Yeah. So we think the role of our cardiovascular system is to provide substrate to allow organs to perfuse and function normally, and then carry those substrates away for clearance from the body. The inability of the cardiovascular system to do that is probably the definition of shock. Now, the problem is we don't have a shockometer or a shock test. We have no single primary variable at the bedside, including vital signs or tests that says this patient is in shock and I can prove it because of X, Y, and Z. And that's why we use a whole cadre of signs and symptoms. And I heard maybe blood pressure or hypotension as one of the defining features. And it is certainly a defining feature of shock. But I think that our cardiovascular system is a little bit more complicated than that. And that's what I want to give you some insight into. All right. So if the inability of our cardiovascular system to supply oxygen and substrate to allow tissues and organs to function normally is the defining definition of shock, how do we recognize it at the bedside? Just shout out a couple of things that you use or have recognized. Hypotension.
Sometimes tachycardia.
Tachycardia.
Altered mental status.
Good. Excellent. Clinical perfusion. You're going to be nutrition?
Surgery.
All right, we'll come back to that in a second.
Body temp.
Temperature. Okay. Anything else? You mean body temperature up or down, or like temperature of the extremities?
Extremities.
Altered mental status.
Ignoring this one, please. Okay. So I think one thing I want you to recognize is that hypotension is a very late sign of shock. So hypotension get thrown out. And so if a patient has absolute hypotension, that I would recognize as a systolic pressure of less than 90 or a mean pressure of less than 60 in the average adult. That should be our defining definition for a patient who has hypotensive shock. But remember, we have a lot of physiologic reserve mechanisms to preserve blood pressure. Said another way, we are neurally built, we are wired to preserve blood pressure at all costs. Our cardiovascular system regulates pressure, not flow. So said another way, whether I'm bleeding or I've got E. coli in my blood or whatever the insult that's causing me to have some cardiovascular dysfunction, my body is protecting blood pressure at all costs. So if I say it that way, would you say that low blood pressure, hypotension, is or is not a sensitive sign of cardiovascular insufficiency? That's a little more complicated. It's a late sign of shock. It's insensitive. The majority of the patients that we will encounter in practice in the throes of cardiovascular insufficiency are going to be in a compensative state of shock, which means they're going to be normotensive. That means our job is a bit more challenging. Okay, so let me first just all recognize that, hey, there is some absolute thresholds that we should probably label as hypotension. Now, earlier said a mean pressure of 60, and I'd probably say a mean pressure of 65 is probably more pertinent for us labeling a patient as hypotensive shock. Okay, I want you to say, when a patient is hypotensive below those thresholds, even when they look well, I want you to believe the blood pressure cuff unless there's a strong reason not to. I don't want you to apply euphemisms. I don't want you to say soft blood pressure or a little hypotension, okay? So blood pressure is it's a late signal shock. It's a dangerous sign. It means all of our physical mechanisms have been overwhelmed. So no different than the label a patient as a little pregnant. I don't want to ever have you all label a patient or a little hypertensive. When you're visiting a patient on the floor that's got hypotension, I don't want you to call your upper level or call your attending and say a little hypotensive. I want you to say, hey, I've got a patient with hypotensive shock on the floor. I need some help. Okay. All right. So let me just add one aside here, which is there's also a concept of relative hypotension. The older we get, we kind of have a tendency to develop progressive hypertension with age. Many of our patients have the comorbidity of hypertension. And so another harder for us to detect because of these absolute thresholds being so easy, but another appropriate way for us to view a patient's systemic blood pressure is what is its comparison to normal? And given the propensity or maybe the prevalence of hypertension in the patients that we manage, i.e. adults, in our society, recognize that a systolic blood pressure greater than 40 from that patient's historic baseline or a mean pressure greater than 25 is probably another defining feature of a patient who's got relative hypotension that doesn't carry the exact same risk, but is clearly higher risk than a patient who would otherwise be deemed normotensive. So I want you to recognize this concept of relative hypotension as well. Okay. Now, if I take an animal or I see a person who's going through the throes of a severe illness, and I do it in an experiment, I see a couple interesting things. So let's just say that this is an animal that has hemorrhage starting at time 0 here. For a substantial number of minutes, depending on the speed of the hemorrhage, that animal is going to continue to preserve blood pressure, right? Remember what I told you earlier, our bodies are built to protect blood pressure. But the animal is having progressive deterioration of the flow of blood to organs. If I can measure the health of those organs, they're deteriorating. So you can define it as a shock, but it's a compensated state of shock, as defined by the ability of the animal to maintain blood pressure. Ultimately, the patient becomes hypotensive. That's what we just talked about here. But in between those things, in between those two periods, something very interesting happens. So if I blow this up and I say this is a 15-minute interval, a patient who's has an ongoing hemorrhage, we'll see something interesting, which is these brief periods of hypotension that in the absence of intervention, correct on their own. Self-limited or transient hypotension. You guys watch American Ninja Warrior?
Oh, yeah.
So American Ninja Warrior, like third obstacle, swinging on the rope, right? Somehow or another doesn't have enough momentum to get to the next ledge. He's swinging. You can tell his forearms are aching. He has like a little slip, but he catches himself. And then you're like, man, this guy really has to get this momentum back to get over to that next ledge. And then 10 seconds later, he hasn't been able to do so. He has a little slip. And you're like, uh-oh, he's only going to last one more time. And then, of course, he falls into the water. Well, the truth is that is exactly what our cardiovascular system does. Okay, when our baroreceptors recognize systemic hypotension, they push out a bunch of adrenaline from our adrenal glands that boost the blood pressure. Transiently, unless we correct the problem, unless we treat with antibiotics or fluid resuscitate or give blood or whatever one of you are doing at the bedside to correct the problem. And depending on the insult, those patients will develop episodic periods of hypotension that then autocorrect, only to deteriorate. Why am I telling you this? Because we see this very frequently in practice. The nurse calls you and says, hey, I need to let you know, Mrs. Jones, blood pressure was 87 when I checked it at the bedside, and I took it again, and it's 105 now. And that may have been an issue with the blood pressure cuff or the patient's arm being folded. But I want you to, when you hear that, right, because nurses are primed to say, Dr. Aware, and inform us when those events happen. I want you to think to yourself, hey, does Mrs. Jones really have a reason to have that event? Do I really think that was artificial or inconsequential? Or was Mrs. Jones in the early throes of progressing to uncompensated shock from an illness you may or may not recognize, and that was the early throes of your opportunity to recognize a problem? Okay? Said another way, almost all of us, almost all animals, humans included, undergo periods of episodic hypotension that they auto recover from in the minutes before they sustain persistent hypotension. Okay, so understanding that happens, it can allow you to recognize it at the bedside. Okay. Right, so I just told you that hypotension is a late sign. And we'll say that the patient has not even had any episodic hypotension for that to be a helpful tool. We mentioned a couple of the things that are helpful. One of the things that was thrown out is heart rate, tachycardia. Okay, and so you're right. I think most of us would recognize that the stereotyped cardiovascular response to a decrease in stroke volume, whether that's due to fluid loss or blood loss or reduced cardiac function, is the compensation of adrenaline increasing heart rate. Okay. And then there's a couple points here. The first is I wish that every patient read the textbook, but they don't. So don't expect every single patient to be hypotensive. There's a lot of reasons for that, but maybe I could just tell you, even among patients that are hypotensive, a third of patients have frank bradycardia or inappropriate heart rate in the throes of systemic hypotension. Without primary bradycardia, heart block, as an example, being the explanation of the cause. Okay, so I wish every patient followed that golden rule of manifesting tachycardia as a sign for us to recognize, but not all of them do. But when patients do, there's also a helpful tool to use both heart rate and blood pressure as a commingled sign. So if I take heart rate and blood pressure, what transformation does that give me as a standardized vital sign concept?
Index.
Yeah, you guys are great. What shock index?
Heart rate divided by systolic blood pressure.
Okay, everybody familiar with it? So in health, our resting heart rate is half of our systolic blood pressure. Okay, so when someone's sinus heart rate or sinus rhythm heart rate starts to approximate their systolic blood pressure, shock index of 1, that is very abnormal. That is 2 times normal. It is a very strong predictor that the patient has an acute severe illness and is at very high risk of deterioration, actually below that threshold of 1. If we want to use this as a test, the sweet spot is actually a shock index of around 0.85 or 0.9. It's easy for you and I to walk into the bedside. And so therein, when you walk to see a patient you've seen before or a new patient to you, and you recognize that sinus rhythm heart rate on the monitor is approximating that patient's blood pressure, I want your spidey senses to go off. I want you to realize this is very abnormal. Let's step back for a second. That can mean a patient with a blood pressure of 105. You say, oh, 105, that's normal tension, right? And then if you approximate or if you add a heart rate of 105, does that give you a lot of pause? Mild tachycardia, right? Neither one of those vital signs alone is a super strong indicator that this patient's in trouble. But by combining the two with your knowledge and recognizing that represents a shock index of 1, that tells you, hey, this is actually a really abnormal complement of vital signs for that individual patient. That makes sense? Good. Okay, so what you guys can learn shock index in your practice it's not specific for any single cause of shock. It was actually developed, interestingly, probably in the late 70s or 80s as an early indicator of symptomatic first trimester pregnant women when we didn't have the ease of doing a lot of early first trimester ultrasounds. It was a way to detect patients who were having hemiperitoneum and bleeding due to ectopic pregnancy. And so that vital sign was very indicative of a patient who were in the early throes of compensated shock due to bleeding. But it doesn't tell us whether the patient has bleeding or hypovolemia, cardiac dysfunction, PE, acute MI, or sepsis. But in all of those conditions, interestingly, there's a very similar threshold of shock index that becomes clinically important. Again, it's that shock index of about 0.9. It doesn't tell you the diagnosis or the cause of shock. It just tells you you've got a patient in trouble. All right, let's jump ahead for a second and talk about organ dysfunction. So you all threw out some ideas about, hey, the cardiovascular system, I'm paraphrasing, supplies perfusion to the organs, and early signs of organ dysfunction could also be indicative of shock. And you're right on. That's exactly right. But what can all be scientists about knowing which ones are specific and the frequency with which they are. Okay. So let me say, ask you guys, there are a couple indoor organ dysfunctions that are measurable and tell me the sign that would be associated with malperfusion as an indicator of shock. Or you were not put? Okay, beautiful.
Yes, I don't know if it's specific to one, but like you get the lactate.
Okay, put it in the parking lot for a second under the biomarker category, but you're right on.
AST, ALT,
Transaminases.
someone say creatinine.
Creatinine, yeah. LFTs. Okay, only our heard sensorium or altered mental status. Okay, and then don't forget your malperfusion. Okay, so like I say, the kidney is the canary of end organ dysfunction. It is the first organ injured in the context of hyperperfusion. And it helps that the kidney is also unique in that we have two simple ways of measuring its function. And so those are but and AKI or delta change in creatinine as a manifestation of ultra-creatinine clearance, so that we label as a patient as having AKI. So again, the canary is the first organ injured in a lot of situations of malperfusion, including patients in compensated shock. So I want you to be very thoughtful about recognizing changes in renal function. We define AKI as a creatinine delta of 0.3 milligrams per deciliter above that patient's baseline. So for many of us in this room who have a normal creatinine, probably somewhere around 0.5 to 0.8, a delta of 0.3 is actually still going to be a normal color on your lab assay, meaning it's not going to be even labeled as an abnormality. So unless you're detecting that difference and checking it yourself, you're going to miss that. Okay. Now it does take a couple hours to manifest. If I developed acute hyperperfusion, now my creatinine clearance is such that it's going to take some time for that creatinine delta to manifest itself. But nonetheless, I want you to recognize using 0.3 as your threshold is clinically pertinent. Urine output is, an immediate manifestation of renal perfusion. What's the threshold that we would label as abnormal? 5, 6, 5 now, the part of that is we get you to respond even to voiding. You have to make sure that the voiding is in manifestation or a way to protect their true urine output or generation of urine output. And you have a patient who thinks in the throes of early shock and you want to use that as an indicator, I would say have a low threshold insert of Foley. And I know there's a lot of impediments to us placing Foleys. I don't want to do it haphazardly, but I also recognize when you think you've got a patient in the early throes of malperfusion, that can be a nice indicator to verify both your concern and the patient's response to treatment. Okay. Someone said liver. Let me just jump to that for a second. Large organ. So in general, I probably say that the organ is fairly, the liver is fairly unique in its dual blood supply. And the fact that it's used to living in this heavily desaturated portal blood flow. So it actually, between dual blood supplies and its acclimation to that situation, actually is relatively resistant to hypotension. And I'll maybe reference a couple of patients using the cardiac arrest. We are in patients with an acute dysrhythmic cardiac arrest and little to no flow for the 20 minutes of CPR that they had. The majority of those patients actually don't manifest severe liver dysfunction. And so just because the liver is just relatively resistant, I wouldn't use it as an early indicator of hypoperfusion or shock. Perhaps with just one caveat, which is an insult to the liver that usually manifests as early transaminase elevation is not just low inflow, meaning low perfusion to the liver, it's high backflow. So patients with cardiogenic shock, patients with massive AE, patients with tamponade physiology, but there's an impediment, there's a big component of venous congestion, are ones that disproportionately develop liver dysfunction. And in those patients, it can be an early sign of dysfunction. That's also a nice reminder that any individual organ's perfusion is actually the delta of inflow pressure to outflow pressure. And that's why the liver is particularly sensitive to elevated outflow pressure. Think of it as a high central venous pressure. And so heart failure, again, acute PE, cor pulmonale, or tamponade would be a very nice example. And that's why you disproportionately see liver dysfunction to that population, but as an example, rarely see it with hemorrhagic shock or severe hypovolemia or even sepsis. Okay. So scout for it, just don't expect it to be an early indicator. altered mental status. Okay, let's talk about that for a second, because we all recognize that altered mentation can be an early indicator of poor perfusion. But I'd probably say that we often use mental status changes or the absence of mental status changes in the wrong direction. We convince ourselves, as an example, that this blood pressure of 85 and this repeat of 82 can't be right. If Mrs. Jones is up and talking to me, asking for a turkey sandwich. Okay, so how do we reconcile those two pieces of information? If a patient really has a mean pressure of 50 and a systolic pressure of 80, how can she be sitting there with normal sensorium?
That in the heart.
Yeah, because your brain has the largest range of autoregulation. So our body is built to autoregulate major organ blood flow around a range of systemic pressure. And the brain has the largest range, including on the downside. Our ancestors in the Stone Ages got tangled up with saber-tooth tiger and had the arm ripped off and lost a liter of blood and immediately syncopized because the pressure went to 80. They became saber-tooth tiger food. They didn't survive to pass on the mechanism of autoregulation and systemic pressure regulation that we have now. And so our bodies are built to preserve pressure even at the low side. So don't let the presence of normal mental status in the context of hypotension that you think is objectively correct to dissuade you that this is not important. I see that used the wrong way more often than not. It is true, however, that even patients that have compensated shock, normotension, can sometimes develop delirium, frank altered mental status, apathy, that we've never had a good understanding of. Why do I say it that way? Is because even in studies, when we do measures of cerebral blood flow in the throes of patients having altered sensorium due to shock and in sepsis, we realize that cerebral blood flow is actually normal. So like I say, the altered mental status that we see in the throes of shock, unless a patient is absolutely having severe hypotension, I'm talking mean pressures in the 40s, is typically actually something related to evil humors. We don't really understand the mechanism. But nonetheless, when you see a patient that has acute apathetic encephalopathy, you go to the bedside, recognize, although not a sensitive marker, it could still nonetheless be an early marker of malperfusion. But you're going to rest on a lot of the other tenets that we talked about earlier to discriminate that. All right, let's move to the skin. And I asked if you were a pediatrician, because I would say in adult medicine, for the last 25 years, we spent a lot of time measuring blood pressures and putting A lines in people and getting PA catheters in and feeling that we could measure blood pressure and blood flow and the adequacy of blood flow from those parameters and normal vital signs, as opposed to looking at perfusion at the bedside. And the pediatricians who didn't have the ability to put a bunch of invasive lines in small children had been using clinical perfusion at the bedside for the last 10 decades. And they have actually now proven that that is just as legitimate as a target. So, in addition to lots of reasons, meaning the things that you'll find when you take socks off of your patients, I would say do a good thorough exam, right? Look at the nails, look at the fingers, look at the digits, look at the extremities, look for markers of malperfusion. And what would markers of malperfusion be? Yeah, so those dark cyanotic changes may be progressing ultimately to dry gangrene would be a late sign. What would be an early sign? What would be the predecessor to that? Yeah. Cold extremities, cold either to the touch subjectively or cold relative somewhere closer in the torso. So you can actually compare the temperature of the distal lower extremities or distal upper extremities compared to farther up on that same limb or on the torso. Did I hear modeling? Pale skin. Yeah, so those are the findings I wanted to look for. And even in the patients who are in the throes of having a normal blood pressure, those findings should be recognized as very abnormal. Okay, and so your job therein is to discriminate when you find them. Is this due to something that's regional malperfusion? This patient's got peripheral arterial disease, or they've got an acute embolus that's gone down the femoral artery, or is this something that's systemic? Is this patient in the throes of malperfusion? What I'm seeing as malperfusion of these extremities is due to intense vasoconstriction, i.e. the body's way of maintaining blood pressure in the throes of decreasing stroke volume. Makes sense. Good. Okay. Talked a little bit about biomarkers when we talked about the kidney. Then I heard a comment about lactate. And if I was to say, hey, when we come to the bedside, we recognize some of these signs, some of them are perfectly objective. Hypotension, shock index as a nice example. A lot of the other ones, especially the clinical perfusion parameters I just mentioned, like skin perfusion, are something that we're kind of using in our experience, right? And that always gives us a little bit of pause and makes us think about whether our finding is really reliable because we don't have a test to kind of confirm it or objectify it. But I would say maybe that test, maybe that best test is lactate. We had to choose one single biomarker as a marker for the patient's underlying cardiovascular physiologic stress, it would be lactate. Okay, so let's talk about it for a second so we know how to use it well. So A, what's lactate in health? If I could draw lactate in all of you well-perfused, well-fed folks, what would it be?
Less than 2.
Okay, everyone agree with that? Can I get a less than 1?
Less than one.
Yeah. So we say 2 is the universal upper limit threshold of normal. In health, most people have a lactate that's less than 0.7. Okay, and we actually have data in patients undergoing elective stress, elective surgery, that small incremental elevations above lactate of 1 can actually put patients in different risk categories of adverse events, organ dysfunction, deterioration, et cetera. Now, the delta between a patient who's got a lactate of 1 and 1.2, 1.3 is relatively small. The inflection point for lactate to be a very potent driver as a signal of a patient in distress that has 2 points. One of them is a lactate of 4. That's part of why we have universalized a lactate of 4 as a diagnostic criteria for a patient, even if they're normotensive, to be labeled as septic shock if they have an infection. You believe a patient's infected, even if they're normotensive, you draw a lactate, you don't have another reason for the lactate to be elevated. Lactate's greater than 4, that defines a patient as having septic shock. And that puts that patient at just higher risk of dying in the hospital as if they were hypotensive. Think of it that way. That biomarker is just giving you some insight to that underlying stress of that patient that is very similar to the presence in that similar individual as having hypotension. Okay, so and anyone who has a lactate between that 2 and 4 range, I call intermediary, it's above or upper limit of normal. It's not at that inflection point of 4. It deserves attention. It probably deserves treatment. It certainly deserves a repeat. Okay. And when we're talking about lactate, while we think of it as a marker of perfusion and stress, maybe I'll comment a couple of things. There's still a lot of metabolic drivers of hyperlactatemia. So I want you to be well versed if you're going to use lactate to recognize that metabolic problems, AKA, DKA, metformin toxicity, tumor burden, some other things that can drive lactate even when that patient is well perfused. Okay, but I'll probably just say those are exceptions. If you had to be a lumper and not a splitter, when you recognize hyperlactatemia, recognizing it as a bad sign, and don't chase zebras, chase horses. Do you have a question?
Yeah, just on the topic of biomarkers, when is it absolutely like you need to get an ABG, a VBG won't cut it?
Oh, good question.
Would you say that that's something that you need to prioritize?
We're talking about for metabolic reasons, not for respiratory reasons.
Sure.
I bet we'll come back around to that because obviously you can get a lot of respiratory information from arterial blood gas, but I get this question as it pertains to lactate a lot. So a lactate of 2 upper limit of normal, we're saying a delta above that of 2 is clinically important. If you're worried about the patient, just order a lactate. Don't rely on a anion gap, a corrected anion gap to be a sensitive tool to discern whether a patient does or does not have an elevated lactate. In today's world, you just order a lactate. When I was a resident, we couldn't get lactate as easily. We were constantly measuring anion gaps. We don't have to do that anymore. Okay. How do you get a lactate? Well, when you're worried about the patient, you can send a lactate to the central lab in most of our hospitals, and it has about a 45-minute, if you're lucky, turnaround time. But many of our hospitals have blood gas analyzers that can run an arterial or a venous sample and give you a full point of care, including a lactate, as long as you order it that way, in about 10 minutes. Our hospital, every hospital in our metro area, my suspicion is every hospital in the US right now probably has one of the same generation of blood gas analyzers. And so wherever you go for your residency, find out how you order stat labs quick. That's usually going to be a blood gas analyzer that can give you a full panel of labs and not just a blood gas. And it can be a venous or arterial sample. I consider those equivalent as it pertains to lactate. Okay. Good.
You know, like your like
recovering overnight in the ICU and you have this patient that's looking weird and you think it might be the compensated shock, the first thing you would do would be the lactate.
I would say that's just a way for you to corroborate your clinical concern.
Okay.
So let's say it another way. A patient comes into the emergency department with tachycardia, normotension. You recognize their shock index is 1 or 1.1. You do a good evaluation. You recognize, hey, that's a very abnormal set of vital signs. That tachycardia is not explained by fever, as an example. You should be thinking hard that that's a marker of cardiovascular insufficiency, and your job to figure out why. Is this patient infected? Are they anemic? Are they hypovolemic? Do they have a cardiac dysfunction, as an example? Yeah, then you would use your physical exam findings and that patient's history to determine which of those diagnostic pursuits you're going to pursue. And I'd probably say at the meantime, a lactate is simply going to give you another corroborating factor. If a lactate comes back at 0.9, you're going to feel very different about that patient and your need to act on it quickly compared to a lactate that comes back at 3.5 or 4. So sepsis, common disease. I'm going to use that as a common example. And so I talked about that inflection point of 4. The inflection point for about a 50% mortality among our patients with sepsis is between 6 and 7. You come in, you're recognized by your team as having acute infection, the lactate comes back at 6 or greater. Despite care in the best hospitals in the country, that portends a mortality of about 50%. That's kind of telling. And here's something that's kind of cool about physiology is if I take, and I've done this, several hundred patients that roll into the trauma room as a trauma room 1 or 2, and I look at the first lactate that was drawn at this, just like the sepsis patient, guess what the what I call lethal dose 50 is for the trauma population, which presumably is dying because of bleeding. It's between a lactate of 6 and 7. So like there's a lot of conservation of the findings that we're talking about. No different than all these vital sign compensatory mechanisms are enacted in multiple different kinds of shock. So are the biomarker thresholds that we use very notable as a way to recognize a patient in the throes of a severe illness or what will be a severe illness. So, right, we use that elevated lactate therein as an immediate trigger to treat based on your best presumption of what you think the problem is. If you're not sure, maybe you get multiple things at once. In the trauma population, it's early blood. If it's a patient who I think has infection as the best explanation, it's get the antibiotics in here immediately. Let's get 30 or 40 acrystalloid on board because I know those are the cornerstones to try to help that patient who I think has a lactate, a shock index, a blood pressure, early signs of cardiovascular insufficiency from that kind of an illness. That makes sense? Good. Did I answer your question? Right, please stop for a second. Any quick questions about codes or water? I think I'm going to jump to just a couple quick things about treatment. Good. Yeah, I think that's what you were asking as well. I'd probably say if we're looking for the metabolic side of our interest, meaning if we're looking for base deficit or lactate as a marker of a patient's cardiovascular unwellness, either sample is legit. They're essentially the same. Why we order it as blood gas is because of its rapid turnaround. So when I'm ordering a blood gas in the hospital during a rapid response team at a code in the ICU, probably 70% of the time I'm doing it because I want the metabolic side of that information, not necessarily the blood gas part, CO2 and the. And so just to make sure I don't cover your bases too, because I think this is a common question is, when can I substitute a venous blood gas for an arterial blood gas in a patient who's got a primary respiratory problem? Well, if I'm worried about hypoxemia, I really think my pulse ox is inaccurate, or I really want to define this patient's degree of oxygenation failure, then I'm going to get a ABG and not a VBG, right? Because the correlation between venous oxygen and the arterial oxygen is too far apart, okay? If I'm going to use a venous blood gas as a surrogate to screen for hypercardia that is clinically important, which I can sometimes do, then I'll use a PCO2, a venous PCO2 of 55 or greater as a marker of arterial PCO2 that may modify my treatment. So I'm really just worried about a patient developing progressive hypercapnia because it's a COPD patient who's fatiguing, or they've got some mild arterial mental status that I don't have a good explanation for, and I think they may be retaining for a variety of reasons, then I can use a EVG as my surrogate, and I'll use PCO2 of 55 as my threshold. Above 55, I probably know the relationship between the venous and arterial PCO2 of about 10, but I'll probably confirm that there's at least some component of arterial hypercapnia. If it's less than 55, it's very unlikely to have a severe component of arterial hypercapnia. I don't even need to check an AG. Does that help you? Okay. All right. So let's say, hopefully, we're capturing all our patients in this early phase of compensated shock before they're hypotensive, even before they've had these transient episodes of hypotension. You guys went this really cool lecture right before you finished medical school. You were Johnny on the spot. You were rounding in the morning. You recognized an abnormal shock index, a malperfusion at the bedside, a patient who was 2 days post-op, a patient who had a fever overnight, a patient that had a big procedure and may have unrecognized bleeding or anemia. And you decide, hey, I'm going to act on it. And so let's talk a minute for a second about how we administer IV fluids in the early throes of a patient who we think is volume responsive. So maybe I'll say this another way, that if you just take all comers, let's just say you have a patient who you recognize and you don't have a good indicator of what the cause of their malperfusion and their abnormal labs are. Okay, no primary indicator that helps you. More likely than not, that patient's at least in the first hours of care volume response. Said another way, hypovolemia, absolute or relative, is such a common construct of patients in the throes of an acute illness and or the primary cause. We should all, almost reflexively, probably consider giving a patient IV fluid. And so therein, let's talk about a couple things for a second. Why do we do it that way? Well, there's a couple reasons. So the first is cardiac output can be no greater than right heart venous return. That's why we say preload is a primacy of cardiac output. If you look at any flow diagram about resuscitating a patient, node number one is volume resuscitate first, in part because of that idea that I just mentioned a moment ago, that giving fluid improves stroke volume, right? Climbing the Starling curve. This is normal to us, but it is historically interesting that 50 years ago, in the late 1950s, there was a very heated debate about what was the impact of fluid administration on cardiac function. But the heart by itself, in response to catecholamine, simply pumped harder and sucked blood as a venous return, or did it require venous return to move pump harder? So we take it as gospel, right? Because we think we've proven that right heart preload is a primacy of cardiac output. So my point is, A, it's common, and B, it is a primacy of cardiac output. So first start with fluid. What's an average, or what's a reasonable aliquot of fluid in the patient in the throes of hypoperfusion that you're going to use at the bedside? That's what I'm talking about. What's our fluid prescription? First off, let's talk about what kind of fluid. What kind of crystalloid, right? Yeah, so isotonic crystalloid, plasma light, lactated ringers, normal sodium. Okay. And then what's your prescription dose? In the throes of a patient got malperfusion at the bedside, what's a reasonable aliquot to give?
Is it
500 liters, 6 years old. So I'll probably say at a minimum, it's going to be 500 mLs. And the patient who's hypotensive, I'll probably say is at least a liter as a reasonable aliquot. Remember that the partitioning of even isotonic crystalloid is such that only about a third of that fluid is going to remain in the vascular space in 20 to 30 minutes. Okay, so a lot of it goes into the interstitium. That's just the price we pay for using isotonic crystalloids. And so if you think about a circulating blood volume in the average patient of about 5 liters, recognize that 500 ml fluid bolus equates to less than 200 mLs of total body expansion. And we under-recognize the ability of venous tone to impact the capacitance vessels to absorb that amount of fluid without improving preload to the right heart. And so I would probably say, certainly in a patient who's hypotensive, and even the patient who's normotensive, 500 to a liter should be our minimum. How fast do we give it?
You want to give it like really fast because they'll just third space it all.
You want to give it really fast because you're trying to challenge this patient's ventricular function system to see whether you correct whatever the variable is that you recognize as abnormal. Does the heart rate immediately respond? Does the blood pressure immediately come up? Does the shock index go down? Does the patient's urine output pick up? does the malperfusion go away? So if you you've got an aliquot of fluid, let's call it a liter, and you put it on a pressure bag with straight IV tubing, you should be able to get that in 15 minutes. Now, I say it that way because unless you tell the nurse that prescription, there may be a delay. What you're seeing as the immediacy for the need to treat a patient and give that rapid fluid challenge may not be recognized by the nurse. So be good communicators. The other default for most of our teams in the hospital is actually to apply fluid on a pump. And the maximum rate on that pump is 999. So unless you want that liter of fluid given over an hour, I think I'm making a case for you to stand at the bedside and give her 15 minutes to see what the response is. You got to make sure you communicate that. I think there's very little downside from the standpoint of how that fluid ultimately gets partitioned to giving it slower. Okay. Now, the caveat here is, and I think you can remember that some of that questions, so I'll come back, is does every single patient tolerate fluid? And I don't want to throw anybody into acute pulmonary edema, but that's something that is talked about, and there's much more concern about that issue than really happens in most situations. And the good news is you've got an easy indicator. You've got a stethoscope around your ear, around your neck that you can listen to the patient's lungs. You see what their respiratory rate is and their oxygen requirement. And as long as you don't have the patient in the throes of severe pulmonary congestion, you should be very confident, challenge the ventricular function curve clinically by giving serial fluid boluses. And if that first liter of fluid doesn't correct the problem, but the lungs are still clear, remember 1 liter of fluid, to your point, because you recommended 30 mLs per kilo, right? Yeah, that's the amount of fluid it often takes to volume expand a patient who is profoundly hypovolemic, in the throes of sepsis, or may have a component of blood loss. Okay, so 1 liter of fluid may be my first challenge. The goal is to get it in quickly, but the amount of fluid that any individual patient can be far, far, far greater than just one or 2 liters.
What is like the role of albumin in these patients, like with shock? Like, is it like a cardiogenic shock patient that you would want to give albumin or?
I mean, I would like you to just think about albumin as another isotonic IV fluid, right? It's just a colloid, and it's a natural colloid, human albumin that's been pooled. We don't have any clear evidence that it has better outcomes nor harm. In the US, unfortunately, it's just way more expensive because the pooled plasma and the albumin component is managed by pharmaceutical companies. You see a lot of papers out of Europe and Asia where albumin is used as kind of a community resource. And so it costs a lot less and they use a lot more. I'm not going to give you, criticize you for using albumin. I'll just say crystalloid's a lot cheaper, widely available. When you start to use albumin, there might be some indications. Patients who have profound hypoalbuminemia, patients who have underlying end-stage liver disease might be a nice example where using albumin as an adjunct, especially in things like sepsis, may have a small benefit. But we're just talking about fluid resuscitating a patient. Albumin or crystalloid should be considered equivalent. Crystalloid just easier. Okay, so that would be a situation where I wouldn't want to give a bunch of fluid. So, and that brings me to a second caveat. I said, what are the situations that I address if needs to be? What are the situations that could make worse by aggressively fluid resuscitating the patient? One of them is the patient who's in acute cardiogenic pulmonary edema, right? So if you've got a patient with heart failure and you've got to put Raoul's on exam and oxygen stats in the low 90s on supplemental oxygen, you probably know this looks like pulmonary edema by definition. This is elevated left atrial pressure causing pulmonary edema. This patient is not going to be volume responsive. And another way, they're literally living on the plateau of the ventricular function curve. They would be manifesting hydrostatic pulmonary edema. Okay. Now, the equivalent on the right side of the circulation would be CVP. Right. So if you've got a patient you has severe right heart function, is in the throes of a right-sided MI, or has a massive PE, I'll probably just mention it this way. I don't want those patients to be hypovolemic, but fluid is rarely part of the answer. Said another way, giving a lot of aggressive fluid, which you sometimes read about in textbooks, to simply use the right heart as a passive conduit to get to the left heart, really doesn't make a lot of sense. Because pulmonary circulation is higher pressure than the CVP. You really can't give so much fluid that follows the laws of physics and is actually in the absence of a right-sided heart that works, you're going to get blood from the right to the left. So you want to systematically not aggressively resuscitate, not over resuscitate patients with right heart failure, irrespective of the cause. So that would be my only other for myself. I'm in the throes of a patient or in the care of a patient who I think is hyperperfused and in shock. listening to the lungs to make sure there's no pulmonary congestion as my, one of the ways to make sure I'm not going to make them worse with aggressive fluid. And then I want to make sure they don't have any significant JVD or right heart failure. Okay. In the throes of giving that patient several liters of fluid, we'll say we give the first liter of fluid, there's a transient improvement, you're giving your second liter of fluid, the blood pressure continues to trend down. What threshold should we have to start vasopressor? We start the vasopressor.
Like they're refractory to volume.
Say again?
When they're refractory to volume.
Okay, so until you've exhausted the responsiveness of fluids.
No, sooner.
After 2 years.
Okay.
After you started fluid resuscitation, but you don't want to leave the fluid resuscitation is completed.
Yeah. Your comment?
I was gonna say, I have a low threshold.
Okay. I think all in all is all right. So it makes sense that if we think a patient is volume responsive in the early throes of hypotensive shock, okay, so our threshold to start norepinephrine, just be titrated to systemic pressure. We're going to target those same thresholds that you think are going to use large people. 65 is our initial target. Because we use one drug, one catecholamine for the rest of your internship year, it's going to be norepinephrine, right? Ubiquitous, wide dosing range, easy to come by, inexpensive. Can you give it through a peripheral IV? I'm going to give it through a peripheral IV. Just make sure the peripheral IV is well established. Don't let anybody talk you out of starting norepi through a peripheral IV in a patient who is in hypotensive shock. The greatest risk to the patient is the hypotension, not extravasation from the peripheral IV. Okay. So it makes sense that if we think a patient may be volume responsive, we should give fluid in order to avoid having to use norepinephrine if we ultimately don't need it. So that goes back to my point a moment ago is keep your fluid challenges fast. You can get a liter of isotonic crystalloid through an IV with a pressure bag, sometimes without a pressure bag in 15 minutes. So that goes to my issue of think the patient's volume responsive, give rapid fluid challenges, sometimes give more than one at the same time as fast as you can. Because then you're going to have the response immediately to know whether that patient does or doesn't need norepinephrine. What I don't want you to do, however, is to take a longer period of time or have a patient who's not responding to those fluids. Maybe the urine output's picking up. Maybe the perfusion of the finger starts to improve, but if the blood pressure doesn't, that's because sometimes patients in the early phase of the illness don't just have a tank that needs to be filled up. They're having progressive vasodilation, literally over minutes or hours while you're taking care of them. When they have that, they need vasopressors out of a bottle. In other words, their endogenous vasomotor tone needs to be supported through catechol. And so I don't want you to tolerate persistent hypotension, even if a patient is awake, like we talked about earlier. Persistent hypotension, and we can now measure this as incremental total number of minutes of hypotension, has impact on organs, especially the kidney that we can measure. Okay. And so I want you to have a low threshold, probably in a patient who you're resuscitating for sepsis as a common diagnosis, probably somewhere around the second liter of fluid. If this patient had persistent hypotension below that threshold of a mean of 60, I would start norepinephrine. Okay. So the nurse turns to you. Does that make sense? Does that threshold seem reasonable? There is a bit of a myth that I want you to also understand, which is this idea of you're going to keep resuscitating until resuscitation no longer works. You never want to give a vasopressor in a patient who remains hypovolemic. Otherwise, you're just going to vasoconstrict the tissue. You're going to make the organ dysfunction worse. Is that true or not? Yeah, so patient's hypotensive. I got 2 liters of fluid going. Pressure bags going. Blood pressure cycle in the mean's 55. I'm like, gosh, I really thought this patient was volume responsive. Maybe they are, maybe they're not. But while I'm sitting here waiting, I don't want this patient's blood pressure to remain in the 50s. I need to start norepinephrine. One historic approach would be, well, get your 30 per kilo in and make absolutely sure that patient is not volume responsive. Because otherwise, if you started the norepinephrine prematurely, you would be vasoconstricting the tissues, right? Norepinephrine is a vasoconstrictor and reducing blood flow to the kidneys, and the liver, and all the other organs that are trying to get perfusion, all the things that you're trying to resuscitate. So that would have been a guard against starting early norepinephrine. But you're going to hear people challenge that, and I want you to understand why. It's okay to get vasopressor. We titrate norepinephrine to a mean systemic pressure, and it's working on the arterioles, right? But remember, it's a vasoconstrictor that hits every population of catecholamine receptors, and the greater impact of any catecholamine is actually on the venous circulation as opposed to the arterial circulation. So while you're giving norepinephrine to improve blood pressure, it's also causing venoconstriction. And almost all of the patients that we're dealing with in the throes of shock have some degree of abnormal vasomotor tone on the venous side. Sepsis would be a classic example where you know that vasodilation is one of the primary causes of their shock, right? But even in the setting of acute hemorrhage, patients, animals develop very rapid loss of vasomotor tone. So norepinephrine actually squeezes the capacitance vessels to improve preload in the first minutes or hours of administration. Key to you all is that if you start norepinephrine, the blood pressure goes to normal, that doesn't mean the patient's volume resuscitated. So you may still need to go back and say, I think this patient still needed 30 per kilo of fluid. Or you may want to do your pornic ultrasound, or you may continue to follow serial HNHs to make sure the patient's not continuing to bleed, needs more blood products, as an example. Okay, that makes sense? I'm going to take a step back for a second because you said, I want norepinephrine. And the nurse goes to you, I got a peripheral IV. I need you to put a central line in. Your response is going to be, does that peripheral, let's be nice. Does that peripheral IV work? Does that peripheral IV work? Great. We need to use that peripheral IV. The hypertension is way more risky for the patient than norepinephrine, and we'll get a central line later on. Okay, good. Then the nurse turns to you and he says, where do you want to start, doc? What dose? Okay, 8 to 12. Well, which one, doc? 8 or 12? 8. Okay. Well, here's what I want you to remember. I want you to remember 7. 7's a lucky number. And the patient in shock needs all the help they can get. It also helps that 7 for a 70 kilo patient is 0.1 mics per kilo per minute, right in the middle of a common therapeutic dosing range. I say it that way because for years we've been telling people just start at 7, and it's easy to remember. And we see people doing it. We've seen a change in practice compared to what used to happen in the past. Because unless you're dealing with a very experienced ICU nurse who's not even going to ask you the starting dose, right? If you're on the floor, if you're maybe in the emergency department with a newer nurse, he or she may say, in fact, I don't use that for you. Go back. Well, many of the order sets will say start at 1 or 2 and titrate every 10, 15, maybe even 20 minutes. So what we recognize that we had a patient who needed a norepinephrine dose of 7 or 8, right in the middle of therapeutic range. But the team started at 1 or 2. The nurse was multitasking, didn't get escalated for several more minutes, didn't get escalated for several more minutes. It took a long time to get to the therapeutic range that the patient needed in order to achieve their target mean pressure of 65 to 75, which is what we are after all along. But I want you to avoid that because if you say start at 7, it's a lucky number. This patient needs all the help they can get. More likely than not, you're going to get an immediate therapeutic response. And if you overshoot, you just toggle back. That's a lot easier. No harm, no foul.
I know like with sepsis, you want to give more epi, but like how do you decide in different situations, which pressure to use?
Well, I'm starting to feel like it's a problem to say that norepinephrine can probably be your first vasopressor for a hypotensive patient all of the time.
Okay.
Right? If your goal was to get this patient stabilized, call for help, let me get more information. Norepinephrine is simple, easy, ubiquitous, low expense. It works, right? If you told me that I had a patient with inappropriate bradycardia, I would prefer epi. I'm going to say, sure, yeah, that makes sense. I'm just trying to say, if you had to just choose and have experience with one catechol, norepinephrine can easily be that choice, and no one's going to criticize you otherwise. No reason preferentially choose dopamine. No reason to preferentially use phenylephrine, even if the patient has tachycardia or AFib. The patient hypotensive shock and you think they need a vasopressor, norepinephrine is an easy go-to drug in all situations. And then you can gather more information over the next hour. Your job right now in this immediate period that we're talking about is just to get the patient's blood pressure up so they're not in danger.
So always just plan on starting in therapy.
I don't know that a nurse ever asked this, but from my understanding, when you say I want 7 of norepinephrine, are they gonna program that in as like 0.1 cc's per kg per, or like on the drip, or like, how is that actually administered?
Yeah, so there's two dosing conventions. One is mics per minute, one is mics per kilo per minute. Every hospital may do it a little bit differently. In general, dopamine and butamine are very kind of universally dosed at mics per kilo per minute. Norepinephrine, phenylephrine, and epi is dealer's choice. And every hospital may say, oh, we do it this way, the other hospital does it the other way, but the two are easily transposable. And every single pump allows you to modify one or the other. So if you say 7 mics a minute, on day 1 of internship, nurse may look at you and say, hey, I'm used to doing it in mics per kilo per minute. And you could either do quick math, or you could just say, hey, I think the pump will let you do 7 mics a minute. And then, I'll start titrating based on mics per kilo per minute from there. All right. I think that's covered what I was intending to know. I think I'm the only thing between you guys and lunch. So, any questions? Let's get 2 good questions. Those are in a psychologist.
You ever use P as a measure?
Oh my God. This is the 201 class, guys. Okay, tell us.
It's pulse pressure variation.
Okay, does everybody know pulse pressure variation refers to?
Is that with the A line? Is that,
It's like the J, the X, and the.
And why does it? That's from the visa side.
Oh.
Okay, so, you go to the bedside, patient's got a pulse ox, they've got an A line, okay? That pulse ox, or that A line is a representation of the stroke volume that is ejected from the heart in that individual beat. I measured an A line, stroke volume. The other reflective waves through the arterial fibrillation. I mean, a portion of the area under that curve actually represents the stroke. So if I'm looking at a pulse ox waveform, it's heavily filtered, which is why it looks so smooth. Although in your careers, many companies are going to be coming out with pulse ox transformations that look very similar to A lines, because they have that. That's actually what it is. This is that going to get here, okay? And if you look closely at a lot of the waveforms of the A lines in today's world, not so much the pulse ox, although some, you'll realize that every single size of each arterial wave is not of the same dimension. Okay? And under the circumstance where the patient's in a sinus rhythm, they're not having ectopy, not in AFib, they have a regular R to R. Filling time is exactly the same. There's not a lot of good mechanisms to say that something underneath, some auto feedback mechanism of cardiovascular control is influencing beat to beat variability of stroke volume. Then you realize, well, what is happening in this cyclical pattern that creates this change in stroke volume in getting fashion? It's actually the influence of breathing. Okay. And so as we realize in patient who's negative pressure breathing, when I take a deep breath, does that augment or does that decrease venous return to my right heart? Decrease. Okay. And so in spontaneous breathing, what I'm getting ready to show you is not helpful. So when we're talking about pulse pressure variation and systolic pressure variation, we're actually going to be talking about it among patients who are positive pressure ventilated. Okay, because while you may see some of these changes on the pulse ox, on the A line, in the patient who's spontaneously breathing, they represent ventricular interdependence. The idea that you have a constrained pericardium and the total volume of the left and right heart is constrained by that pericardium, and the influence of breathing influences that. But when a patient's on positive pressure breathing, prevails is the positive pressure breath that's going down into the lungs from the ventilator. When I'm on positive pressure breathing and I get a breath, does that increase or decrease stroke volume preload? Maybe I should say it that way, to the right heart. Right, so positive pressure breathing is an impediment to venous return. That makes sense? Okay. And so what you'll recognize in patients who are on the ventilator, and in sinus rhythm, that when you see this reciprocating fashion, you're seeing a patient have a positive pressure breath and transiently changes preload to the right heart. That decreased stroke volume goes through the pulmonary circulation. Several beats later, that decreased stroke volume gets ejected from the left ventricle into the arterial circulation. And you see it as a decreased stroke volume several beats later. And you typically see it in this kind of diminishing pattern. So every positive pressure breath associated with a decrease in accompanying stroke volume several beats later. That's the concept of pulse pressure variation, systolic pressure variation, stroke volume variation, the fact that the stroke volume is varying as a function of positive pressure breathing on the ventilator. When you see that, what it is telling you is something very fascinating that we don't have knowledge of at the bedside otherwise, which is that that individual patient is living on the ascending limb of both their right, and their left ventricular function. So when you're on the ascending limb of your ventricular function, you are volume responsive. So when we are resuscitating a patient and we're sitting here thinking, but if fluid, is it the right heart? And this kind of a change, it unequivocally tells us this is an incredibly good certainty, a patient who is volume responsive. Giving a fluid balance is definitely going to improve stroke volume in cardiac.
Would that be like a higher PPD would mean that they're fluid responsive?
Exactly. The threshold is about 13%. The variation per cycle, per increment of time of about 13% is the research discovered sweet spot for all of these variables to predict that a patient is volume responsive. 13% or higher, they're volume responsive. 13% or lower, they're unlikely to be. Yeah. And so you may be seeing this more and more in the future. Probably more cardiac output monitors. There's a lot of minimally or non-invasive cardiac output monitors that go on the finger, that go on the arm, that will actually give you hemodynamic parameters, like what is this individual patient's stroke volume at a moment in time. So you'll be able to use that as an aid to resuscitation. Identify whether it's abnormal or normal in the throes of managing a patient with the responses if you give a fluid challenge. The stroke index is 20, and you give a rapid fluid challenge, and the stroke index goes to 30, and prove that the patient was volume resuscitation. All right, that was a complicated question, but a good one. All right, any other questions? All right, work hard. Get rest, be humble, eat a lot. Oh, can I give you guys my my recommendations? How to survive Residency? I got a couple. They really are take care of yourself. If you could read one book this summer, I'd want you to read a book called Why We Sleep. It will convince you of the power of sleep and how you need to protect it. And you all may have different sleep characteristics and sleep patterns. Learning your sleep pattern, your sleep characteristics, and optimizing them and making sure you get the amount of sleep you need is important to your health, including your professional wellness. Okay. The second is have fun. You're going to work with a lot of tense situations. Anytime you're asking for help from a consultant, you think about tracking someone, go back to the basics. Thanks for calling me back. I need your help. Goes a really long way to even a grumpy, who should I say is grumpy, cardiac surgeon at 3 a.m. Okay. And lastly, how do you continue to digest this enormous amount of medicine? Well, you're going to see a lot of patients in practice. But it's probably going to be common for you to be so immersed in patient care, so immersed in the details, and so immersed in so immersed in the potassium rotation that sometimes you lose the aspect of learning the fine medicine. An easy thing that I've done literally my entire career since I was an intern, and every single day, I print out at least one article. And I usually wear a white jacket. I'll keep in my white jacket, otherwise I'll keep my back pocket. Over the course of that day, I'm going to find 10 minutes of downtime. And if I do that every single day at work, I'm going to have read by definition 300, 400, 500 articles I wouldn't have read if I hadn't taken that step. So whenever you get to your internship, go to your desktop, create a folder. Anytime someone sends out journal club articles or interesting editorials or interesting research articles, anytime you come across something, just dump it in that. You come in for rounds, print your list, print your article, you'll get through it that day. I guarantee it. Okay? Habits.
Dr. Hester, we're gonna move right into our next lecture. I'm sorry, we're running a little behind. So you can do like a 2-minute bathroom break.
What about lunch?
We have lunch.
Lunch is going to be like 12, maybe, it's gonna be a little bit after 12:30, but you'll have till 1:30. Our next lecture isn't till 1:30. So, we have a couple speakers that you'll be doing a working lunch today. That's why the schedule said working lunch. So it's just a matter of grabbing lunch real quick and bringing them back up.
Are we supposed to get that now or?
No.
No. So none of the-
Yes.
Way.
That does sound pretty good.
Yeah. 10 minutes.
One time there, I waited there literally for 20 minutes.
I always live it. I ordered the app as I pick it up.
But sometimes they just.
No.
Oh my gosh. It was stressful. Lots of.
I don't work. What about IM? Look at IM. See, so did I got.
I don't think I saw you in my month.
I'm keeping it. I
You were too, I see.
decided.
No, I didn't want one thing.
What?
You have more authority.
But no one with that discount, you should have done it. What is it, like a $50 discount?
It's $3.
That's crazy.
I saw, you know how much it'd be at Starbucks?
Yeah,
And
20.
so people are using the vanilla core powder and then put it in Dunkin' coffee.
Yeah, that's smart.
That's what I wanna try.
Yeah.
I don't need to wait.
They said this was way.
So apparently,
It is dairy way.
so
Nice, Joey.
she's being filmed today.
Oh, right.
She has
You
her
never get any more.
social media
information about-
debut. They gave me some questions.
Okay, so you have some answers.
By the way, the questions are like, what were the questions? The questions are like, yeah, the questions are like, what's your name? Where are you from? Like, why did you decide to become a doctor? And she's like, I better be able to read off the script. Like, you got this.
You have your.
So milk protein, Joey was explaining this to me, she's allergic to milk protein, so she can't have whey. But some people are lactose intolerant and they can have whey. Apparently like lactose and whey.
Lactose is different than,
Yeah.
it's not the protein, but is this whey protein or is it milk protein or are they?
Whey protein and milk protein are the same, but you can get lactose intolerant and be able to have.
Like an internal medicine.
Do we think that? That's good to help. I think too.
Okay, so I've looked it up. Summer, it depends on how crunchy you're trying to get it.
No, I like